Hi, I'm Daniel Lodge, a cardiac surgeon in St. John's, Newfoundland. Today I'm going to be talking to you about endocarditis. First up, we'll speak about the modified Duke criteria for diagnosis of endocarditis. There are pathological criteria, major criteria, and minor criteria that we will discuss in detail. First up, we have the pathological criteria. By definition, these require a sample that is obtained surgically or by some other invasive method. First of all, you can have microorganisms that are demonstrated by culture or histological examination of a vegetation that is embolized, or an intracardiac abscess specimen, or pathological lesions where a vegetation or intracardiac abscess confirmed by histological examination showing active endocarditis. There are two major criteria in the Duke classification of endocarditis. You can have a positive blood culture for infective endocarditis, and that would be a typical microorganism consistent with endocarditis from two separate blood cultures. You can have persistently positive blood cultures of microorganisms consistent with endocarditis, and at least two positive blood cultures drawn greater than 12 hours apart, or all of three or a majority of four or more separate cultures of blood, with this first and last sample at least 1 hour apart. Or you can have a single positive blood culture for Coxiella burnetii or antiphase IgG antibody greater than 1 in 800. Or you can have evidence of endocardial involvement. So that would be an echocardiogram positive for infective endocarditis. And that would include things such as an oscillating intracardiac mass on a valve or structures, such as basically a vegetation, or evidence of an abscess, a new partial dehiscence of a prosthetic valve, or new valvular regurgitation. Worsening or changing of a pre-existing murmur is not sufficient for a major criteria diagnosis. There are 5 minor criteria in the Duke classification of endocarditis. You can have a predisposing heart condition or intravenous drug use. You can have a fever with a temperature greater than 38 degrees Celsius. You can have vascular phenomena such as major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, and Janeway lesions. You can have immunological phenomena such as glomerular nephritis, Osler's nodes, Ross spots, and rheumatoid factor. Or you can have microbiological evidence that is not qualified for a major criteria, but does qualify for a minor criteria, such as a positive blood culture or serological evidence of active infection consistent of infective endocarditis. Once we have identified our pathological, major, and minor criteria, then we can actually apply that to the diagnosis of endocarditis using the Duke criteria. So to have definite endocarditis, you need 1 or more pathological criteria, 2 major criteria, 1 major and 3 minor criteria, or all 5 of the minor criteria. For possible infective endocarditis, you can have 1 major criteria and 1 minor criteria, or 3 minor criteria. And to reject a diagnosis of endocarditis, you can have a firm alternative diagnosis explaining evidence of infective endocarditis. If the infection resolves with less than or equal to 4 days of antibiotics, it's not endocarditis. And if there's no pathological endocarditis, that's surgery or autopsy with antibiotic therapy less than 4 days and does not meet the criteria of possible as above. There are clinical guidelines that you should be aware of for the diagnosis and treatment of endocarditis. The 2014 AHA and American College of Cardiology guidelines for valvular heart disease provide some good guidelines on infective endocarditis, and there's also a 2016 AATS consensus guidelines for the surgical treatment of infective endocarditis. Shown here is a summary flowchart from the 2014 AHA endocarditis guidelines. So once you have somebody who has definite or probable endocarditis, then you need to, number 1, give antibiotics, and then you need to evaluate the need and timing of surgery. So anybody that's got valve dysfunction causing heart failure, a resistant organism like Staph aureus or fungi, heart block or abscess, persistent infection despite adequate antibiotic treatment, they should all undergo early surgery. And the AHA guidelines define early surgery as surgery during the initial hospitalization before completing a full course of therapeutic antibiotics. There are some weaker guidelines for early surgery in the AHA guidelines, and they include a large mobile vegetation on a native valve, and that's a class 2B indication, or if there are recurrent emboli and persistent vegetation despite antibiotic therapy, then they recommend early surgery as a 2A recommendation. There are also recommendations if a PACER or ICD is present, and particularly if the PACER or ICD is infected, then early hardware removal is indicated. If the leads and device pocket are not infected, then it's a 2A recommendation to remove the pacemaker hardware. In 2016, a group in South Korea published an article in New England Journal of Medicine based on early surgery versus conventional treatment for infective endocarditis. And there's also a follow-up to that of long-term results of early surgery versus conventional treatment for infective endocarditis. This study was a small study with a total of 76 patients with left-sided infective endocarditis, severe valve disease, and vegetations greater than 1 centimeter. These patients were assigned to either early surgery or conventional treatment, and the primary endpoint was a composite of in-hospital death and embolic events that occurred within 6 weeks after randomization. Here in the results, you can see that there is no difference in survival between early surgery and conventional treatment. However, there was a very statistically significant difference in embolic events in the conventional treatment group, and the early surgery group was better. So based on these results, many people will now perform early surgery for endocarditis if they have left-sided endocarditis with severe valvular disease and large vegetations. Before taking anybody to the OR, you'll be often asked, is there any additional preoperative workup you would like prior to going to the operating room? The first question that you usually get is, would you like a coronary angiogram? The 2016 AATS guidelines provided some nice guidance on what you should do prior to taking somebody to surgery for infective endocarditis. As far as the coronary angiography goes, they should be guided by normal criteria. If somebody is of an age and has risk factors for coronary artery disease, then they should probably have a coronary angiogram, particularly if the person had previous coronary artery bypass grafting. For people with large aortic valve vegetations, most interventional cardiologists are loath to put catheters into the aortic root and shoot dye into the coronary arteries because they're very concerned about embolizing some of those vegetations. So in that situation, CT coronary angiography is an alternative to assess the coronary arteries. Another common question is, would you like a CT scan of the head or the chest, abdomen, and pelvis to look for emboli? And the AATS guidelines from 2016 say that it is reasonable with a 2A recommendation to obtain brain imaging prior to going to the OR. More recently, evidence has been emerging for IV antibiotics versus oral antibiotics in the instance of infective endocarditis. Some places have outpatient intravenous antibiotics available, but it is not always convenient for providers or the patients. So this article was published in the New England Journal of Medicine for partial oral versus intravenous antibiotic treatment of endocarditis. And what they looked at was a primary composite outcome of all-cause mortality, unplanned cardiac surgery, embolic events, and relapse of the positive blood culture. The 4 components of the primary composite outcome were not statistically significant. Shown here in graphical format, intravenous versus oral treatment was not statistically significant. Current guidelines for endocarditis prophylaxis with cardiac disease are indicated for people with prosthetic cardiac valves, people with previous endocarditis, people with cardiac transplants and valve regurgitation due to a structurally abnormal valve, or patients with congenital heart disease, including unrepaired cyanotic congenital heart disease, completely repaired congenital heart defects with prosthetic material during the first 6 months, or repaired congenital heart disease with residual defects at the site of a prosthetic patch or prosthetic device. And they say that prophylaxis is not recommended in patients with valvular heart disease who are high risk of endocarditis for non-dental procedures for things such as TEE, OGD, colonoscopy, or cystoscopy.